All right, now we're going to discuss, again, the adverse effects of anti-epileptic drugs. These are the things you're going to be tested on. These are the things that you're going to need to know when your patients get these. Phenobarbital can have sedation, nausea, ataxia, rash. It can also have Stevens-Johnson syndrome, acute liver failure, anemia, thrombocytopenia, and leukemia. Phenytoin can have sedation, dizziness, ataxia, rash, Stevens-Johnson syndrome, anemia, thrombocytopenia. You can feel the pattern here. Leukemia, gingival hyperplasia is a big one, phenytoin. If you see pictures, if you ever want to look that up on the internet, there's very specific pictures on that. Acute liver failure, drug-induced lupus. Pregabalin can have sedation, waking. It's very similar to gabapentin. Edema, watch for kidney function levels can accumulate. All right, continue discussion of adverse effects of anti-epileptic drugs. Topiramate can have anorexia, aphasia. This is where you have to watch kidney stones. Topiramate can also be used for migraine treatments too. You can have acute glaucoma, heat stroke, metabolic acidosis. Asian patients have a higher risk of hypersensitivity reaction to aromatic AEDs. This is carbamazepine, lamotrigine, oxycarbazepine, and phenytoin. There's suggested genotype testing for the HLA-B1502. This has been listed as board questions. This has been in reviews before. And who is this in this Asian populations? I know this is a big group, but Han Chinese. Han Chinese, and this also can be one of the dominant groups in China, have a higher risk for having and need to have the genotype testing. Oral contraceptives induce hepatic enzymes and metabolize the medications, making them inactive. Continue discussion of adverse effects. Generic drugs. So let's go through this. Now, there's some great books out there, and they talk about how generic drugs, even though we take them as being as good as the equivalent, sometimes they're not. Because the generic, when you get the generic, it's not they copy the formula. They have to do something similar. They can't copy the process. So what happens is, especially on the extended release medications, it may not work as well. The drug itself and the extended release may not work as well. Now, I'm not trying to say is that we don't avoid generic drugs, is just be aware of it. Generic drugs, the bioavailability of the drug can vary up to 20% between manufacturers. These are things that we're not taught in school and we have to learn the hard way, and our patients can suffer because we don't know. Try to keep the same manufacturer to prevent variability, especially in these drugs, because we can have this issue on these anti-epileptics. And it could be someone, all of a sudden somebody's doing well, and all of a sudden they start having seizures because the brand has been switched. They're getting a generic levetiracetam, and they switch the brands of levetiracetam without the patient really knowing, and they can have variability, especially on the extended releases. Lamotrigine and oxycarbazepine are sensitive to estrogen, have to uptitrate dose during pregnancy. Lamotrigine has an FDA warning for a systemic immune reaction, can have fever and rash, enlarged spleen, cytopenias, high triglycerides or low fibrinogen levels, high ferritin levels. Hey, we talked about this. Hemophagocytosis detected via bone marrow biopsy, the spleen or lymph nodes. What is this? Reduced natural killer activity. We discussed this. Increased levels of CD25. Lamotrigine can cause HLA, hemophagocytic lymphohistiocytosis, HLA, hemophagocytic lymphocytosis. We discussed this, and we discussed the criteria for this. It can induce this. Lamotrigine can induce this. And there's 8 diagnostic criteria. Valproic acid can inhibit enzymes in the urea cycle, and they can have elevated serum ammonia levels. So you need to check the ammonia and valproic acid in patients that are confused. So what's the treatment? You discontinue the valproic acid, give lactulose and L-carnitine. L-carnitine is going to be the key. That's going to hit you on the board review. L-carnitine. Other side effects can be weight gain, tremor, hair loss, acute liver failure, pancreatitis, aplastic anemia, thrombocytopenia, and platelet dysfunction. Phenytoin toxicity. is horizontal nystagmus, ataxia, slurred speech, altered mental status, has many drug-drug interactions, can have hepatic and renal disease, can have decreased serum albumin, can result in higher phenatonin levels, can have hypertrichosis, is defined as excessive hair growth anywhere within the body, either for males or females. You could take this medication if you flunk out, which you won't, which you can become a bearded lady if you want to, something different in life. Gingival hyperplasia, this is the big one for phenatonin, that will help distinguish it. Peripheral neuropathy. IV infusion has side effects such as hypotension, bradyarrhythmias. Let's talk about causes of death in epilepsy. Drowning, sudden death in status epilepticus can have sudden unexpected death in epilepsy, SUDPEP. Risk factors: generalized tonic-clonic seizures in a prone position after a nocturnal seizure, basically is not protecting the airway. Frequent seizures can have recurrent seizures, long postictal, and you can have postictal breathing problems in cardiac arrhythmias, can have inadequate therapy and rapid withdrawal therapy. These poor people, the things that they go through in these seizures, it's a tough lifestyle. Mechanism can have respiratory arrest, laryngeospasm, suffocation in prone position, can have pulmonary edema, and that's the most common autopsy finding in patients who have unfortunately died with epilepsy. Hypercarbia and hypoxia, common after a seizure. Prevention: seizure control with proper medications, avoid sleep deprivation, and avoid excess use of alcohol. In patients with nocturnal tonic-clonic seizures, increasing the evening dose of the medication. After seizure, reposition the patient on their side, to lay on their side. Stimulate patient, you want to protect them from if they have apnea or severe hypoventilation. All right, honestly, this is going to be the toughest seizure you treat. Psychogenic non-epileptic seizures, you see, formerly this is known as pseudo-seizures. Now it's going to be, you'll see the abbreviation PNES, PENS, in the medical records. It's a type of conversion disorder where patients remain unaware of why they're having events and usually have a history of abuse. They can have forced eye closure. These can be hard to distinguish, and I've seen actually people who specialize, epileptologists who specialize, neurologists who specialize in seizures. I can even see them fighting if these are PENS or not. This is in spite of having all these devices that we have. Remember, the EEG is not perfect. We are not perfect. The EEG is not perfect. If they're very extreme long seizures, hypermotor active, like they're really flopping around, that starts and stops. Management, man, these are tough to manage. Inpatient video EEG monitoring required for diagnosis, high level suspicions for the diagnosis, especially those who have not responded to or more anti-epileptic drug therapy. And you may have patients who have real seizures and PEN seizures too. And that's where it's very tough to manage. Treatment, removal of unnecessary AEDs is critical. Referral for psychological resources provide the best chance for treatment and outcome. These are tough situations. These are tough to discuss. These are tough to discuss with the families. The families have been dealing with these seizures for years, and then if you say they're fake, this is not going to go well. These interviews and these discussions usually can be pretty tough. All right, here's another example. Look at this. We're having ventral tachycardia of our brain. This is an example of status epilepticus and EEG. Remember, you're not expected to read EEGs. Treatment of status epilepticus. We talked about this is 0 to 5 minutes. First line is going to be lorazepam. And you have to worry about respiratory suppression. And guess what? If you have respiratory suppression, you intubate the patient. You need to protect the brain because the brain is having a storm. You're trying to protect the brain. First line, you can give lorazepam 4 milligrams, IV mirtazapine 10 milligrams. Also can give 10 milligrams IV thiamine and IV dextrose plus 500 milligrams if hypoglycemic or unhealthy alcohol use disorder. If for 5 to 10 minutes and we're still having seizures, IV phosphatidylcholine or IV phenytoin, IV valproic acid can also be used. Let's go back real quick. If still having convulsions, this is the 10 to 20 mark. Remember, you want to suppress this as soon as possible. You want to protect that brain, protect those neurons. Now, you probably have maybe already had to intubate the patient. This is where you consider, and then IV anesthetic. This is where we're going to use to probably IV mirtazapine, propofol, or phenobarbital. If convulsions discontinue prior to intubation, attain a head CT. If persistent, altered metastasis, continuous EEG monitoring. These can be tough to treat, and we need to think about how rough this has to be for their families. Is that, can you imagine watching your loved one just not doing well, and you may feel that your provider is not giving assistance or is ignoring or not believing what's going on. Remember, we talked about propofol. We're going to talk again about propofol infusion syndrome. We talked about it in the critical care session, but remember, everything's tied together, and we need to have links to everything so we help remember things better. We have space-based learning, so we're going back and learning things again. Propofol infusion syndrome, you can have a metabolic acidosis, rhabdomyolysis, arrhythmia, renal failure, and myocardial failure. Use a medium of about 3 days, 1 to 6 days of starting the infusion. Because impaired electrolyte transport chain function caused by propofol. This is why we follow the patients closely, and we check their serum CK levels. Immediate discontinuation, we stop the propofol immediately. We need to give supportive management, including possible hemodialysis, hemodynamic support, and at extreme cases, they may require ECMO. Non-convulsive seizures. So low as 8, up to 48% of comatose patients may have non-convulsive seizures. Delay in diagnosis and treatment is associated with severe high mortality. There's no single clinical symptom. There's no clinical exam that we can use as perfect. Subtle signs may be rhythmic twitching or myoclonus, aphasia, mutism, amnesia, eye deviation, maybe some autonomic instability. Sometimes you'll see patients' pressures drop. So what was going on was these patients, these big centers, what they did is they said, you know, we have these patients in our ICUs, and these patients are extremely altered. They're not doing anything. Let's put EEGs on them. And in these studies, the patients up to 30, 40%, they were having non-convulsive seizures. They're laying there. They're not something that they're not doing the tonic-clonic. So we didn't think about it, and these patients were harmed. These patients were harmed, and we missed diagnosis. So that's why I implore you to put EEGs on early, and even if you can't get the EEGs, consider putting an anti-epileptic on and getting EEG. I know that some people will disagree with that, but if you have somebody that suffers or has harm because we didn't get the diagnosis fast or quick enough or the right diagnosis, just think what a travesty that is. All right. 52-year-old female gets throbbing headache, nausea, vomiting, light sensitivity when she travels in North Carolina. This is a very specific thing, and this is a migraine. And we're going to talk about migraines now, and we're going to do some board-style questions, but I also want you to think about migraines as being globally affecting somebody's body. You can even look at an example as Miss Branson made international news when she suffered a migraine, caused her to speak incoherently during her on-air report in the Grammys. This is back in 2011. 2011. You can look this up. And what was going, she was talking, all of a sudden she started slurring her speech. Some people thought she had a stroke. Some people thought she was on drugs. Some people thought the devil possessed her at that time period. But no, she had what's called a complex migraine. So let's go through our unfair board review question. What is the most appropriate first-line acute treatment for migraine attacks? This is a 32-year-old female who presents with recurrent episodes of severe unilateral throbbing headache for the last 48 to 24 hours and is accompanied by nausea, photophobia, and phonophobia. She reports physical activity worsens with pain, and sometimes she experiences visual disturbances before a headache. She has no history. This is really important. I know we didn't do our normal thing where we read the answer stem first. This one, very important, no cardiovascular disease. What is the most appropriate first-line acute treatment for migraine attacks? Sumatriptan, propranolol, amitriptyline, topiramate, and then we're not even going to read this. This is a thing that you can inject that people use for their wrinkles. These also can be used for treating migraines. But what is the most appropriate first line? Sumatriptan. Okay, sumatriptan. Let's go over here. We're not going to say the brand name, but you can see Botoxilum is part of that. So that's not the brand name itself, but it gives you an idea. So sumatriptan is going to be first line, and we'll talk about the first line. Propranolol can be used as prophylaxis. Amitriptyline is prophylaxis. Topiramate can be prophylaxis. And the Botoxilum can be prophylaxis. Migraine diagnosis. Pound mnemonic for migraine diagnosis gives a probability of 92% in patients who report at least 4. 3 is about 64%. 2 or less is 17%. Where the headache is pulsatile, at least 1 day duration, 4 to 72 hours, unilateral one side of the head. You have nausea and vomiting, and disabling. Having 4 or above, have at least, and you have a 92%. All right, auras can be in 30% of migraine episodes. Some patients have a positive aura with visual lights and paresthesia. Negative aura is visual loss with numbness. You can have it one side or another, which can be purely where you have an aura. It can be a retinal migraine. You can have a brainstem aura where you have vertigo, ataxia. So these are just not in your head. Remember, is no triptan therapy when someone has a brainstem aura. No triptan therapy. So brainstem aura, let's go through it again. Vertigo, ataxia, dysarthria, diplopia, that's double vision, tinnitus, and then altered mental status. No triptan therapy. Episodic migraines occur less than 15 days a month with nearly 3 episodes per month on average, usually lasting less than 24 hours per episode. Chronic migraines occur more than 15 days a month and at least for more than 3 months with headaches possessing the feature of migraines for at least 8 days per month. 2% of the population has this. Treatment of migraines. Non-opioid analgesics have been found to be effective for mild to moderate migraines. Triptan is a drug of choice for treatment for moderate to severe migraines. Triptans can be used, they have all sorts of methods now, subcutaneous, orally, they have nasal sprays, they have the oral disintegrating tabs. Triptans cannot be used in patients who have poorly controlled hypertension, severe hepatic or renal impairment, basal or hemorrhagic migraines, so basal or hemiplegic migraines, coronary artery disease, vasculitis, pregnancy, or cerebral vascular disease. Increased risk of serotonin syndrome if triptans are used with an SRI or selective norepinephrine uptake inhibitor. Side effects can be paresthesia, flushing, neck tightness, and chest pressure. Limit use less than or equal to 2 days a week to avoid medication overuse headache. Treatment of migraines. Acute management, the goal is to return to normal function within 1 to 2 hours of treatment and remain symptom-free for 24 hours. NSAIDs, triptans, and DHE can be used. DHE is last choice for those who do not respond to sumatriptans, do not use in pregnancy, coronary artery disease, and vasculitis. All drugs should be evaluated after 3 episodes for effectiveness. Status migrainosus is a attack duration greater than 72 hours. Can you imagine having debilitating attacks for greater than 72 hours? Can require glucocorticoids for outpatients and IV DHE, usually over 3 days with fluid resuscitation and parenteral antidopaminergic drugs. DHE binds to the 5-hydroxytryptamine receptors, resulting in vasoconstriction and inhibition of the trireme release of inflammatory peptides. This is why you would want to avoid this on cerebral vascular disease. Other medications can be Formazimab, Irinotamab, which are 1 weekly subcutaneous. Side effects are at the site injection. Treatment of migraines, prevention of menstrual headaches. Methylphenic acid 2 days prior and up to end of menstruation. So these methylphenic acid can be given migraine with, or you need to avoid OCPs because you have an increased risk of stroke and DVTs. NSAIDs and acetaminophen daily, concerns for medication overuse headache. Remember, NSAIDs, we have the risk of what? We're going to have increased edema. We can have GI side effects. We can hit our kidneys. And remember, we can have GI bleeds. Prophylaxis of migraine is indicated for patients with frequent, greater than 2 times a week, or severely debilitating migraines. What can you consider is propranolol, timolol can be used. Tricyclic antidepressants such as amitriptyline. What do we worry about an amitriptyline overdose? Remember, we're getting all these things together. Prolonged QRS. What is the treatment? IV what? IV sodium bicarbonate. Use calcium channel blockers of verapamil, anti-epileptic medications of valproic acid, topiramate, which has a risk of what? Of kidney stones. For asthma patients, consider avoiding beta blockers and may consider topiramate as being one of the answers for them. Migraines, triptans have possible side effects of serotonin syndrome and can have chest pain. Razatriptan is the fastest, less side effects. Naratriptan lasts longer, slower onset. Sumatriptan is oral intranasal injection, has more side effects. Dietans, serotonin agonists, have side effects of dizziness, sedation, cannot drive for 8 hours. Lamistidine does not cause vasoconstriction for those who cannot take the triptan due to vascular disease. Gepants, these are used for patients with cardiovascular risk factors, causes vasodilation. The CGRP, calcitonin gene receptor peptide. These are types of medication that are designed specifically to help to treat migraines. Abortive therapy can be Europant. Rimipant can be given once a day. Prophylaxis with Agatripant and Rimipant every other day. All right, this is a 56-year-old male with no past medical history. His wife noted that he's been clumsy and was making fun of him. What did this gentleman have? This is a sad case right here. We're going to get it right here. This was a sad case because the wife felt bad as this patient. She was making fun of him for a long period of time, saying he's getting clumsy, he's getting older, but he had ALS, amyotrophic lateral sclerosis. Pretty sad case. The wife was pretty tore up about it. All right, in this case, we have a 58-year-old man who presents with 8 months of progressive right hand weakness and muscle atrophy. He reports frequent muscle cramps and fasciculations. On examination, there's atrophy in the intrinsic hand muscles with deep tendon muscle reflexes in the upper and lower extremities with mild dysarthria. Sensory examination is normal. Remember, sensory is normal in ALS. Sensory is normal in ALS. I'll say it again. Sensory is normal in ALS. EMG reveals widespread denervation and reinnervation in multiple regions. What is the findings most characteristic for ALS? Upper and lower motor neuron signs in multiple body regions. ALS is defined as a progressive degeneration of upper and lower motor neurons, particularly presenting with combination of muscle weakness, atrophy, fasciculation, and spasticity without sensory loss. Without sensory loss or early involvement of adductor or sphincter muscles, diagnosis is supported by clinical and EMG evidence and evidence of both upper and lower motor of involvement in multiple regions. So fasciculations, let's look at an example of fasciculation. See that? It's a fast tremor. Let's do it again one more time. Okay. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, where motor neurons are associated with progressive weakness and muscle wasting. They have progression of motor loss of motor neurons in the cerebral cortex, brainstem, and anterior spinal cord. Usually presents with focal weakness, muscle twitching, cramping, speech problems or swallowing. Results in death from respiratory failure within several years. Aspiration is a major cause of death. Upper motor neuron signs are hyperflexia, spasticity, extensor plantar response. Lower motor neurons can be wasting and fasciculations. AML, continued discussion. You have asymmetric weakness in both upper and lower, with both upper and lower motor signs. Muscle twitching and tongue fasciculation. Can have hyperflexity, spasticity in weak atrophic limbs suggesting ALS. Can have dysphagia, aspiration pneumonia, dysarthria. Weakness of the ventilator muscles causing respiratory insufficiency. Absence of pain, no sensory changes, normal bladder and bowel function. Here is very important. Normal sensory, normal bladder, normal bowel. That differentiates it from spinal cord compression. Primary lateral sclerosis is a rare variant of ALS with primary upper motor neuron features, hyperflexia, but no wasting and or fasciculations. All right, ALS. Diagnosis is based on examination, EMG, and ruling out alternative causes. EMG shows denervation in affected muscles. CSF will be normal. MRI shows, occasionally will show a T2 bright signal in bilateral cortical spinal pathways, suggestive of ALS. Differential diagnosis, we need to rule these out. Lyme's disease, hyperparathyroidism, thyrotoxicosis, benign fasciculation syndrome. Treatment, supportive treatment, which could be CPAP, BiPAP. Some people will be on the ventilator and they would get a trach. Ranolazole, which is a glutamate release inhibitor, may slow progression by 3 months at most. Sad disease. All right, a 67-year-old male noted for sudden right-sided upper and lower extremity weakness and difficulty speaking. So right upper and lower extremity weakness, and we get, what do? What are we gonna do first? We're gonna imaging. All right, now this image right here is not from that patient. Why can I tell you this? Because this is a severe ischemic stroke, but this is later onset. On that discussion we had, the patient, it was sudden. This is not sudden. This tissue has been worn out for a long time. So remember, brain tissue, saying it's not anaerobic is not completely accurate. The brain uses a lot of oxygen and it can go through it pretty fast. It can carry some aerobic, but not much at all. It's not very efficient. So that's why this tissue, it requires a lot of oxygen. It's not great in anaerobic and it's very insufficient. And that's why we can get this damage to this tissue. You can have rapid cell damage and death from this. So we can lay on this arm and we'll feel pain and we'll get this arm, we'll move this arm and get blood to it. So we can constrict this arm right here. We put a tourniquet on this arm. I would have the pain, but I'd still be able to do some aerobic metabolism. Brain is very limited and it requires so much oxygen. So that's why when it gets an interruption in blood flow, this is why we have damage to the brain. As you can see it in the CT imaging. All right, let's go to an unfair, because none of them are going to be fair. What is the most appropriate next step in management? Administration of intravenous alteplase. Start dual antiplatelet therapy with aspirin and clopidogrel. Lower blood pressure to 140/90 before initiating therapy. Begin full dose anticoagulation with heparin. I want you to think about in strokes, in acute strokes, this is probably never going to be the right answer. This used to be the right answer a long time ago, but now we can cause harm. Especially, can you imagine if you gave this gentleman heparin right here, and this is kind of a recent stroke, increased good bleeding. You can cause harm. Remember, first do no harm, right? First do no harm. This is a 68-year-old male with past medical history of hypertension, type 2 diabetes mellitus, who presents to the emergency department with sudden onset of right-sided weakness and aphasia that began 90 minutes ago. His blood pressure is 170/95 and blood glucose is 110. Non-contrast CT shows no hemorrhage and early ischemic changes. His NIH stroke scale is 12. So this CT for this gentleman shows no early ischemic changes. So the answer is going to be intravenous alteplase. Now, there's other medications now that's probably going to be used in your facility. It's going to be called TNK.